This is Professor Michael Chapman. I'm one of the most experienced IVF doctors in Australia. I believe that an important part that I can contribute is to educate patients in relation to fertility, infertility, and all that involves. These series of podcasts help to educate you. I hope they are helpful to you. If you wish to know more, however, I'm more than happy to have you contact me via email, which is profmchapman@gmail.com, or make an appointment to see me on 9138 4222.
Question from Jen. For recurrent miscarriage, what baseline testing is truly worth doing, and what results actually change your treatment plan?
Okay, well, so if you've had more than 2 miscarriages, these days it's called recurrent miscarriage. Something like 60 to 70% of those miscarriages, once you get to 5 or 6 weeks of pregnancy, due to random mix-up of the genetic material in the embryo. Random aneuploidy. It's called aneuploidy, meaning it's not the right number of chromosomes. And nature basically does a good thing. It actually gets rid of those in the vast majority of cases. So that's the 60 to 70%. What we then do is go looking for other things. The first thing we go looking for is that there is a chromosome imbalance in some people who are absolutely normal because they've got the total normal amount of genetic material. It's just that one piece of one chromosome has actually jumped onto its partner in the pair of chromosomes. The significance of that is that when an egg is formed, or when a sperm is formed, one of the eggs will have the extra piece of chromosome attached to it, and one egg will have a missing bit, and that missing bit will cause a miscarriage. In 50-50 chance, if there's what's called a balanced translocation, we'll end up with a miscarriage. Half of them will miscarry, which is 1 in 2 is much higher than the background rates of miscarriage. So we do go looking for that, and that means doing something called a karyotype on each partner to exclude that. We find it in women or couples with recurrent miscarriage in about 1 in 150 cases. So it's not common, but if it happens, what we then can do is do IVF and then genetically test the embryos and only put back embryos with the extra bit of chromosome, and that will solve the problem. So that's the genetic side of it. The next thing we go looking at is the uterus. Is the uterus normal? Is the shape of the uterus normal? Is there fibrous tissue or scarring tissue within the uterus, maybe from a curette that was done for a previous miscarriage? It's caused scarring inside the uterus and therefore making it difficult for an embryo to grow. So testing that is the first step in that is what's called a sonohistogram, an ultrasound test where we put dye inside the uterus and look at the shape. Beyond that is actually looking inside the uterus with a very tiny telescope called a hysteroscope, again making sure that we have a normal shaped uterus, and if we see scarring or adhesions, we can actually remove them at that time. Then beyond that is the environment that the woman is suffering, is that a cause for the miscarriage? Now, the evidence for all of these things is somewhat marginal. There's something called antiphospholipid syndrome, which is actually a definite, that's a proven cause of increased miscarriages. And we can test for that in a blood test looking at some immunological factors. Some doctors do a whole pile of immunological tests and almost always will find something. Because if you do 20 tests on anything, of any biological activity, you will find one that will always be abnormal. It's just the random chance. And they justify giving steroids and intralip and all sorts of stuff that really, the evidence is not good. Well, there is no evidence that they are actually positive other than anecdotal evidence. Thyroid disease in its most serious form, yes, there's a higher miscarriage rate. But if you have something called subclinical hypothyroidism or hyperthyroidism, makes no difference. Miscarriages are the same. There was a theory about blood clotting, called thrombophilia, excessive likelihood of bleeding, and it was rational in the sense that if you make blood clots more quickly, maybe you block the placenta and that causes a miscarriage. Big studies published in the Lancet a year or so ago showed no increased risk of miscarriage if you had those factors that might suggest you had thrombophilia. But we do look and we do treat either with aspirin or a blood thinner like Clexane. So, they're basically the tests that I would run you through. There's one more on the male side. We've talked about the female, but on the male side, there is evidence that breakdown of the genetics, the chromosomes in the head of the sperm, called DNA fragmentation, increases the risk of miscarriage. And so, again, that's a test that we would do routinely in women or couples where there is recurrent miscarriage. I think that's covered all of them. In terms of overall treatment of recurrent miscarriage, I am very positive about the future, and that's my number one reassurance. So if you've had 2 miscarriages, doing nothing in the next in your next pregnancy, there's more than a 75% chance you're going to deliver a baby with doing nothing other than letting nature be normal. Once you get up to 5 or 6 miscarriages, however, the risks of another miscarriage rise substantially to being 1 in 3 through to almost 1 in 2 if you've had 5 or 6 miscarriages. The options in terms of medication to try and prevent miscarriages, progesterone given intravaginally in threatened miscarriage, in other words, women who are bleeding who've had miscarriages before, increases the chances of having a baby by about 8%. It's not huge, but it potentially makes a difference. What's going on out there in the big social media world is, I had a miscarriage, so next time I want to use progesterone. Yeah, it does no harm. It's expensive, but really it probably doesn't make any difference after 1 miscarriage. I talked about saying that random aneuploidy was the major cause, and that random aneuploidy, that aberration of chromosomes, increases the older the woman is when she tries to conceive. So at 30, that risk is probably maybe 30% of all embryos that we put back at IVF that are tested at 30 have genetic abnormalities. By 45, it is 95% of them will be genetically abnormal. At 40, it's more like 70 to 80%. So one option, if you're having recurrent miscarriages, is to go through IVF and only put back a genetically normal embryo after we've tested it. And that's been shown to reduce the miscarriage rates down to 2 or 3%. So it is a major step, but we don't necessarily recommend it after a couple of miscarriages. You have to be a 3-timer probably before I would push you in that direction.
And don't forget that you can access all the previous episodes by going to our website www.theivfjourney.com and select IVF Journey podcast from the navigation menu.